Hello, everybody. My name is Mirvat Alasnag. I'm an interventional cardiologist at King Fahd Armed Forces Hospital in Jeddah, Saudi Arabia. And with me today is Dr Abdulrahman AlMoghairi. He's an interventional cardiologist at Prince Sultan Cardiac Center, and Dr Khalid AlJohani, an interventional cardiologist at King Saud University, Riyadh. We had co-authored an article for US in Review on left main interventions, and we're going to try to discuss it over the next few minutes with all of you. So welcome, gentlemen, and thank you for taking the time to be here today. Dr. Jenny, I would like to perhaps start with you. What do the current guidelines recommend for PCI of left main?
Well, as we know that as the evidence from the randomized control trial is evolving in the latest big RCTs like Noble and Excel, the guidelines from the European has moved into class 2A for ostial and shaft left main intervention with a class of evidence B, and class 2B for intervention also, which push the left main intervention towards more and more closer to CABG, as the evidence now support that it could be, and if it's used, especially intravascular imaging, you can get near CABG results, which helps improve the outcome.
Yeah, I agree with you. And there's certainly a difference in practice between ostial and then distal left main or mid-shaft disease. So PCI can be considered an alternative to bypass surgery for select patients with unprotected left main. But clinical outcomes of PCI do vary depending on the size and the complexity of the lesion. And specifically, distal left main is more complex and associated with worse clinical outcomes. I mean, we do see, Valgamigli and Suarez, who did their research and T-research registries showing higher MACE with distal left main that was primarily driven by TBR. It was 30% versus 11%. So really the optimal intervention for distal left main continues to evolve, but most of the left main studies do endorse a provisional strategy. Even then, we know that 40% of left main interventions are performed with an intentional upfront two-stent strategy. And this wide variation is really highly dependent on the anatomy and stent types and operator experience, perhaps. And I think the final comment that I'm going to make is from Kanzari and his group that did a sub-analysis. They examined procedural methods and outcomes in patients who had undergone distal left main PCI in the Excel sub-analysis. And they note that 3-year adverse outcomes were worse with planned two-stent treatment compared with provisional one-stent approach. And this was confined, though, to patients with major involvement of both vessels. So, Dr. AlMoghairi, if we focus on the ostial left main, what techniques do we use to optimize the positioning of ostial left main patients?
Yes, thank you for the introduction. The left main, though, it's looks the easy intervention, but it's a challenging because the ostial by the CT from the different observed from different studies and published in the your intervention by CT, which showed about 85% the geographic mismatch or geographic miss to miss the ostium. And currently, the commonly used methods is the fluoro-guided, which takes the multiple views from the ilio-cranial, iliocaudal, areocranial, from the apicaudal, according to the anatomy, because the anatomy, not all the anatomy is the same. And so the difference is the anatomy which dictates the positioning. But there are many techniques to help precise positioning of the stent. One of them is the floating wire technique, which use the 2 wires, one in the target vessel, which is the LAD to the left main, and the other wire floating into the aorta to stop the guide from diving in to precisely localize. The additional step also to make this floating wire into the proximal part of the proximal stent cell of the stent, which called Szabó's technique. This is good, and also to stop both the guide from diving in and the stent from getting deep and precisely. But the drawback of this technique it may cause some deformity of the proximal part of the stent, which can be managed with the post dilatations and optimization. And the third one is a dedicated device, which called ostial probe. It's a dedicated device to stop or to localize the ostium for precise positioning. And knowing the available drug-eluting platforms and also the position of the stent or relation of the stent to the markers of the balloons also is very important for the operators to be aware of the platform, whatever the stent they use. The third part is the optimization balloons, also to take care of the optimizing the stent, or what they call it is a flare, or to use the dedicated flare balloons or devices to optimize the stent, whatever the protrusion they prefer. Is it 1 millimeter protrusion, 2 millimeters, or flashing at the ostium? Then finished by the utilizing the imaging, which can be covered by Dr. AlJohani later in the talk. Those are the main aspects of the localization, optimization of the ostial stent.
So maybe it is a good time to turn to you, Dr. AlJohani, about the role of intracoronary imaging to optimize left main stenting. What is your thought? Is it mandatory?
Yes. So intravascular imaging, be it IVUS, which is the ideal and most commonly used in left main intervention because of the technicality, although been described the use of OCT in also left main. But the usual or the most commonly used intravascular imaging modality would be an IVUS. I think, in my opinion, and the opinion of most of the operators I meet across the international platform, they would advocate for the use of mandatory use of IVUS during any left main intervention. As we know, left main is an important vessel, and it supplies the majority of the myocardium, and there is no place for luck or chance or experience. You really have to have an optimal result first by sizing the stent. It will help you not only to diagnose and diversify a significant from non-significant left main. It also can help you to size your stent appropriately and to know if there is a size mismatch, and to plan your procedure with single or a double stent strategy. And at the end, it helps also to optimize your results, because having a malabose stent in the left main is no good and is associated with target lesion failure, and it will impact the outcome. If we want to compete with surgery as being the standard of care, I think any left main PCI should not, and it should be class 3 if no intravascular imaging is used. There is exceptions, of course, if the patient is unstable, if the patient is in an acute situation like STEMI and maybe unavailability. I would suggest that maybe re-imaging the patient in a center where there is an IGS technology available. And one important also point, especially for the young generation of interventionalists, using the IVUS is one thing and understanding the IVUS is another thing. Advocate yourself to go to courses, ask your senior members who does IVUS a lot, because IVUS is easy to be done, but you have to really know what you're reading, because there is certain parameters that you have to know. What's the MLA, MSA, how to size it yourself, train yourself at the beginning. And I think the best thing is to just stick to your senior member in the cath lab. They would help you, and there is many courses online. There is a lot of material available and books available to guide you to really excel in IVUS. And IVUS is, I think, what will be a game changer for interventional cardiologists and interventional procedure when compared to surgery.
That was really brilliantly said. And, just a side note, the EBC Main trial and the DK Crush 5 trial, both were very relevant studies that are really shaping the guidelines for left main PCI. The uptake of intracoronary imaging in both trials was approximately 40%, so it wasn't exactly 100%. But other differences between these two trials is, of course, the EBC Main was a European trial that captured outcomes of a stepwise provisional strategy for distal left main disease. And they found that the primary composite of all-cause death, MI, target lesion revascularization, was about 14.7 versus 17.7, which was insignificant. In DK crush, the 3-year outcomes were reported and target lesion failure occurred at about 16.9% in the provisional. It was significantly lower in the DK crush group at 8.3%. And that was primarily driven by target vessel MI and target vessel revascularization. Perhaps the differences in outcomes in these two trials is really because the syntax score was higher in DK crush, the lesion length was higher in DK crush, but both trials required operator experience, which is something you also alluded to. But I'll turn back to you, Dr. AlMoghairi, and there is a lot of discussion about using mechanical circulatory support in left main. So if you could just sum that up for us, what do you think the role of MCS in general or left main PCI is?
Yeah, I think the most challenging part is the definition of the high risk. So the high risk definition is until now is not unified. Which one is the highest risk to use the? There are certain parameters to take in considerations. One is the LV function. The LV systolic function impaired is one of the criteria. Complexity of the anatomy is one of the criteria. The presence of ongoing heart failure or elevated in ADB based on the pressures taken prior to the procedure. Multiple comorbidities. The higher the comorbidities is the higher the risk. High ischemic burden by the imaging or non-invasive testing. The blood pressure, baseline blood pressure at beginning of the procedure. Those are the maybe parameters to take in considerations to consider the using the mechanical support devices during the intervention for the left main. Then the selection of the device, which device to use. We know from the past the intra-aortic balloon pump gives the very minimal or maybe no support to the very high risk procedure, but gives some placebo effect to the operators. The other devices, which is major invasive like the ECMO and tandem heart, gives highest support, but carries the high risk in particular. What's commonly used is the Impella, in particular CB, which gives high output or high support and utilized in up to 30% of the total devices used in the mechanical support. The drawback of the mechanical support, is very helpful, very supportive, and makes the lengthy procedure successful. But the drawback of those devices is the vascular complications, which is approaching 5% in the Impella cases compared to 14% with the ECMO, and also up to maybe 45 or 44% in the tandem heart. So the higher the support, the higher the complications, which is the drawbacks until now. Maybe within the future, with coming down with the range, with the size of the devices, may make those devices less complicated and more utilized better. But their use is probably essential in certain cases, which is the highest risk gain the maximum benefit from the mechanical support device.
Well, thank you, gentlemen, very much. We do discuss these points at length in the review article, along with other points, but perhaps for the future, we really do need to look at operator experience and training and how we can get our operators to the level where they're comfortable with what needs to be done in terms of technique and imaging and so on, but also kind of explore geographic differences. We have seen a difference between EBC main conducted in Europe and DK crush conducted in Asia, and perhaps it's worthwhile seeing our region as well. So thank you very much.